Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
Are you ready for another case study? People seem to like the case studies. After I did the aortic dissection case study, and then I put out the debrief for the surgical airway that we did, I got a lot of DMs, messages, Snapchats. Not really. But I did get a lot of DMs from people telling me, I'm really glad you brought back the case studies. It's been a while. They're really good episodes. Thank you for that feedback. I very much appreciate it. It's not that I haven't wanted to do case studies. I love doing case studies, but as you know, I sound like a broken record at this point. I went through a months-long dry spell where I just had a bunch of boring routine shit that wasn't really worth talking about. It's not that I didn't have sick patients. It's just that, to use a Seinfeld parallel, it just wasn't podcast worthy. And I am showing my age. Actually, I had lunch with my best friend this week, and we were talking about using Seinfeld references and how we are beginning to feel old because we use them and people look at us and they have no idea what we were talking about. Anyway, let us do a case study. I did the aortic dissection case study. That was a really sick patient. Very, very surprisingly, she's still alive. That is very surprising to me. So yet again, it just goes to show that what we do matters. That woman certainly could have died during transport to the hospital and then not gotten the surgical intervention that she needed. Is she doing well? I don't know. I hope she is. But it just goes to show that I really think, and I'm not saying this because of me, if Cam had her, she would have taken great care of her. If any of my coworkers had her, she would have been in very good hands. And I'm sure if any of you took care of her, she would have been in very good hands. But I truly think that without good pre-hospital care, she would have died. She would not have survived to get to the hospital to get the intervention that she needs. So lesson learned, what we do matters. I posted that episode, and that night I went to my flight team job and we had a rockin' good night. I was working with a great nurse, Nick, and we had a pretty busy night with a couple of pretty sick patients. And one of them is going to be the case study that we are going to talk about now. This was a sad case. Spoiler alert, it did not have a good ending. Well, it didn't have a good ending for the patient nor his family, but I am a firm believer that with bad things comes some good, and some good did come from this. A bunch of people are going to get or have already gotten organs from this guy. So spoiler alert, the guy died. But let's talk about the case study because there's a lot of important lessons to learn. And this was kind of if you are an experienced critical care medic, experienced flight medic, or ICU nurse, you're going to be thinking this is a bread and butter case, but it is a bread and butter flight team case, but good case study. And I think that we need to talk about it because pre-hospital 911 EMS, you don't get a lot of this information in your initial and continuing education. So here we go. I will shut up and let's get to the meat and potatoes of the case study. We are dispatched to a local community hospital. I am not a community hospital hater. This is a pretty good one. As far as smaller community hospitals with limited resources, I do think this is a pretty darn good one. We are called to transfer him to our big tertiary care center with blah, 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 all the capabilities in the world. Once we accept the flight, we are never told what we are getting initially before we accept the flight, because when they call us, they want us to make the decision to fly or not, strictly based on safety, weather, weights and balance. Can we do the mission and all the risk assessment stuff? They don't want us pushing weather. They don't want us pushing a potential maintenance issue that we know about or maybe sitting on. We don't want to push those things based on an emotional decision. That's why they don't tell you what you are going to before you accept it. So you don't want to go like, oh, the weather's bad and maintenance is supposed to come in and look at this, but this is a 3-year-old who's dying, so let's go get them. No, we don't want to make emotional decisions. strictly based on safety and a risk assessment. They will simply tell you, you have a flight request, here's the pickup location, here's the drop-off location, and here's the patient weight, and whether there's any special equipment or not that is required. And once we say yes or no, well, really, if we say no, then the conversation ends. But once we say yes, they will then give us the report. We accept the flight, and we are told that it is a 130 kilogram patient that is pushing 300 pounds in freedom units. It's a big boy. And the diagnosis is status epilepticus. So the pilot's doing his pre-flight checks. We get an email to our iPhones with more information on the flight. We are going for a 26-year-old male who was, quote, found down at his place of employment. He had seizures en route to the hospital for EMS. The medics gave him Versed for his seizures to no avail. The ED gave him 2 more doses of benzodiazepines to no effect either. They started him on a Keppra infusion. He is intubated and he is on a nicardipine drip for blood pressure management as his CT head showed a, quote, large frontotemporal subarachnoid hemorrhage. So that sucks. 26 is friggin' young for this. Very tragic. Just with those notes and without even laying eyes on the patient, you know that this guy is, I'll say, gravely ill. The most likely etiology is that he had an aneurysm or an AVM that ruptured, causing this giant subarachnoid bleed that will look like a starfish on CT scan. That's an FPC question. And hence the subarachnoid bleed is why he's having seizures and altered mental status. Very, very critically ill. We are taking him to the neuro ICU, but I should specify that there is a very good chance that when we arrive, they're going to say, hey, actually, we're not going to the ICU. We're going right to the OR table. But we will frequently bring patients right to the neuro ICU or any ICU, and then they rapidly will take them to the OR. And that's what happened here. Since he's going to the neuro ICU, we can probably deduce that it is not traumatic in etiology. At my institution, he certainly would have gone to the trauma ICU if there was any chance that this was a trauma. So likely this was a ruptured AVM or an aneurysm. I think most people probably know what an AVM is, but if we have any students listening or people who straight up don't know, which is fine, I have certainly been the guy in class sitting there thinking, I'm the only person who doesn't know what the hell the instructor is talking about. And I've raised my hand and said, hey, this may be a really stupid question, but what is X, Y, and Z? So if you're one of those when I talk about an AVM stands for an arteriovenous malformation. And this is where arteries and veins become entangled and they don't form normal connections. So instead of a nice smooth connection, you get this big, ugly rubber band ball looking thing that is often like an aneurysm. It's weak and it's prone to rupture. An aneurysm is a little bit different. An aneurysm is a weakened part of a vessel wall. That weakened part balloons outwards because it doesn't have the structural integrity of a, I guess, regular vessel, for lack of a better term. And that portion that is ballooning outward and thin, like an AVM, is prone to rupture. Aneurysm or AVM, for our intents and purposes, it really doesn't matter. Both are prone to rupture and both are extremely common causes of spontaneous head bleeds. Most commonly, a subarachnoid hemorrhage. So I think we all can agree that this guy is not in a good situation, not good at all, but he's 26. He has that going for him. I have seen, kind of like the aortic dissection patient that I talked about, that I was like, hey, I think she's probably dead. She's not dead. Just goes to show that I have seen patients who were absolute train wrecks, who I thought were going to be vegetables or permanent heads on a stick, is one neuro ICU nurse called them. I've seen them end up walking out of the hospital with no permanent deficits. A couple of years ago, Bill and I flew a 30-year-old who collapsed at work. The story was that he grabbed his head, started screaming, said he had a severe headache, and he fell to the ground, had a seizure, and then was stone GCS of 3. He had a catastrophic, massive subarachnoid bleed. And when we got to him, his pupils were fixed and dilated. He's intubated. He's on no sedation or analgesia whatsoever. The doctor told us that he intubated him without drugs. And this guy was seemingly a brain-dead centerpiece during the transport. He seemed to have no reflexes that neither we nor the ER doctor could identify. And we both were, while we were flying this guy, we were like, he's dead. They should have just withdrawn care at the community hospital and brought in his family. And they ended up doing a craniotomy on him. They evacuated the bleed, and amazingly, he ended up walking out of the hospital with no permanent neurologic deficits. And this is a guy where the textbook and experience would tell you he's a goner. I have a collection of similar stories, so I won't repetitiously bore you, but I have seen this happen right up to the ripe old age of 78, where we were bitching and moaning on the way to pick up this patient that we were going to be flying a cadaver to just die at a different geographical point. And he ended up being okay. I'm not saying that that is the norm. A lot of these patients do die. But the point is that neurosurgery is amazing. Neurosurgeons are amazing, despite being sociopaths much of the time. Some of these patients are quite viable. That is the lesson. But while potentially salvageable, this guy is sick. He's got one foot in the grave and another on a banana peel. Now, not all of your subarachnoid bleeds are going to be actively trying to die. Sometimes you have somebody with a very small subarachnoid bleed, and they simply have a very severe headache, some hypertension, and some nausea, and they don't require a surgical intervention. They'll be admitted to the neuro ICU. They'll get routine neuro checks, an occasional CT scan to follow up and see how they're doing, and careful blood pressure management, but they're quite stable and they don't require neurosurgical intervention. They run a full spectrum from stable-ish patients like that to patients like this guy. Regardless, this is a bad condition to have, no doubt about it. These patients are sick, and not only are they acutely ill and they are at risk of permanent stroke effects and death, but they have a lot of associated downstream complications in the hospital, like fever, infection, seizures, and arrhythmias. You can get a subarachnoid from a medical etiology, like we already talked about, or you can get it from a traumatic etiology. And it is sometimes a question of the proverbial what came first, the chicken or the egg. It is not uncommon to get a patient who suffered a fall. They have altered mental status and obvious signs that they whacked their head, like a laceration or a big contusion. The hospital puts them through the CT scanner, spins their head, and they find that they have a subarachnoid bleed. Now, if it's a subdural bleed that they find and not a subarachnoid, it's almost certainly going to be from the fall, from their head hitting the ground and those bridging subdural veins shearing. But if it is a subarachnoid bleed, it can be tricky to tell whether the fall caused the bleed or whether the patient sprung a bleed that then caused them to fall. I didn't go deep diving or really read anything as far as data on the what came first thing in preparation for this episode. As you know, I'm not a neurosurgeon nor a radiologist, but I do remember bringing this one guy in from a community hospital who had a subarachnoid after falling down the steps. And we roll into the trauma bay. The guy's got a massive laceration and really ugly head trauma. And the trauma surgeon pulled up the CT scan from the sending facility and he just went, nah, that's aneurysmal. So I guess maybe you can tell, but for our intents and purposes, we just don't know. Does it really matter though for us? No. Medical or traumatic, we treat them the same. So let's go down the treatment pathway for these patients using this particular patient as a guide. This guy presented as a seizure with a severely reduced GCS. Seizures are mandatory to treat. This isn't like the epileptic who had a seizure in the back of the ambulance where you can wait a minute or two to see if the seizure stops on its own. These seizures are provoked seizures due to an angry and sick brain. They will increase the oxygen and metabolic demand of the brain. You want the brain to be relaxed in these patients. It's already taxed enough. So if you see seizure activity, treat it promptly, and that's exactly what EMS and the ED did. So bravo. They treated him with benzodiazepines. Unfortunately, this didn't really do the trick. The ER added Keppra, which really isn't a seizure rescue med, but it is an anti-epileptic med that is down the status epilepticus pathway. So that was certainly appropriate. The guy didn't get ketamine, but ketamine would have been a great option for this guy. He needed airway management, certainly. So ketamine would have been a fantastic drug to give this guy for airway management because there is all sorts of data out there that ketamine suppresses seizure activity in the brain. And some EMS services have already added it into their seizure protocols. As always, follow your local protocols, but I think that you're going to see ketamine be a mainstream med for refractory seizures in EMS protocols in the future. And I hope it's the near future. So this patient has continuous seizure activity and a deep level of altered mental status. He has no ability to protect his airway. He is a high aspiration risk if he hasn't aspirated already. Actually, I think I remember them saying something about finding a large amount of vomit at the scene, so he probably did aspirate, and that certainly jives with a subarachnoid hemorrhage that often presents with an acute onset of a severe headache that is maximal at onset, often described as a worst headache of their life or a, quote, thunderclap headache, and it is very often accompanied by nausea and vomiting because there is increased intracranial pressure and that causes nausea and vomiting. Sometimes very aggressive vomiting, sometimes projectile vomiting. I had one patient once that I picked up with a subarachnoid and he had a GCS of 15, but man, he was just miserable. And he told me that he's like, I feel like I have to stare straight ahead. Every time I move my eyeballs or I turn my head, I have to vomit. It sucks. So always remember, these patients are extremely uncomfortable, nauseous, excruciating headache. Always remember to treat their pain and their nausea. But back to the loss of an ability to maintain an airway and being a high aspiration risk. This guy's got to be intubated. No ifs, ands, or buts about it. Always resuscitate before you intubate. Yes, mitigate hypoxia that may exist before you push meds and intubate them. But dare I say that typically these patients don't need a ton of resuscitation prior to intubation because they are hemodynamically stable. Actually, they are usually hemodynamically in the other direction than what we typically worry about in an emergency pre-hospital crash airway. They're often very hypertensive. Now, you don't want to willy-nilly drop the blood pressure and just go, oh, fuck it. I'm not worried about the blood pressure. No, that can cause a whole host of other problems. Follow protocols, be judicious and smart about it, but usually you can administer a properly dosed induction med and paralytic and intubate the patient without too much worry about their blood pressure crashing. I have seen it though. Often it is due to a failed airway attempt, aspiration hypoxia, and multiple intubation attempts, which is no bueno. So just goes to show, maximize first pass success rate, ear to sternal notch positioning, appropriate pre-oxygenation, have suction ready, have it turned on, video laryngoscopy, and I always recommend using a bougie, even though I am kind of like jumping on the rigid stylet train. You want to maximize first pass success and mitigate any chance of hypotension, hypoxia, or hypercarbia. Those are the, quote, 3 horsemen of the apocalypse in TBI and patients with increased ICP. Even just one instance of one of these in one of these patients, and this is no bullshit, will statistically double their mortality risk. So this guy gets tubed. They said it was a no factor tube, easy tube, no issues. Then what happened? Well, I have to be honest here. As good as I think this sending hospital is, they did what I see absolutely fucking constantly at referring facilities all over the place. I saw it on both flight teams that I've been on now. I see it repeatedly. I have now done patient flights from North Jersey to Virginia and everywhere in between, and I have seen this time and again. What am I talking about? What did they do? Or rather, what did they not do? Well, they started the patient on a post-intubation management regimen that included sedation and no analgesia. The patient was on a Versed infusion with no pain meds. They did say that they gave 1 dose of fentanyl after the intubation, but that was like an hour prior at least. And as you know, a push of 50 or 100 mics of fentanyl lasts like 15 minutes, maybe 30 if you're really lucky, but that is pushing it. And when we arrived, this guy had tears streaming down his face. which is a telltale sign that they are in excruciating pain. So we promptly gave him a hit of fentanyl to make him more comfortable. I mean, come on. This guy's got the worst friggin' headache of his life, and now he's got a piece of plastic shoved down his throat. He's on a ventilator, on an assist control mode that's blowing positive pressure into his chest. None of that is comfortable. Unless you are using ketamine for sedation. Benzodiazepines and propofol do not do jack squat for analgesia. And reminder, neither does your paralytic. These patients need pain meds. Sedation is important, no doubt about it. But while they look docile and they look completely comfortable, you have just sedated them to the point where they can't move their muscles to show you that they are in pain. These patients need pain meds. So be on top of that. Know your drugs. Know how long your meds last. If the patient is on a continuous infusion of Versed or propofol, that 25 mic hit of fentanyl that they gave 30 minutes ago isn't going to be doing the trick. The patient is having enough of a bad day. Please be diligent and smart about making them comfortable. End of rant, off of my soapbox. Okay, so he's intubated, he's sedated, he's now pain controlled because we gave him fentanyl, and he doesn't appear to be seizing anymore, at least not visibly. Now, who knows what an EEG would show, but for us, he ain't shaking and he's manageable for us. He's flaccid, he's not doing anything, which also isn't necessarily a good thing. But I did consider the tears from the pain to be a promising sign that something was going on up here, upstairs, up in his brain, and that his brain was at least functioning enough that he was sensing pain and responding to it. But I don't know if that meant anything. I forget which one. I think it was his left. It doesn't really matter. But one of his pupils was like a millimeter or two bigger than the other. That's another sign of increased intracranial pressure that's getting bad to the point where the patient is about to herniate. So with increased intracranial pressure, that's the big problem here. Think of intracranial pressure, ICP. Think of it as afterload in the brain. The body has to push against that afterload to perfuse the brain. The more pressure there is, the less perfusion to the brain. The brain gets pissed off, and it does what any other injured body tissue does. It starts to swell. It becomes inflamed. Well, there is this whole hard skull encasing the brain, so the brain has nowhere to swell but downward through the foramen magnum. And this is the Monroe-Kelly doctrine at work for you neuro nerds. So this is not good because the brainstem is located in the area of the foramen magnum, and the brainstem is a sensitive little bugger. It does not like it when the rest of the brain encroaches on its territory. Since the brainstem controls the vital functions, it demonstrates its displeasure with the encroachment on its territory by causing derangements of the body's vital functions, like respiratory pattern changes, worsening altered mental status, and bradycardia, to name a couple. These are signs of herniation, and eventually the patient will die. So what is a girl to do to prevent herniation? Well, either drill into the head and drain the hemorrhage, you put a ventriculostomy in, or you take the skull off and evacuate the hemorrhage in the OR. None of us can do that because we aren't neurosurgeons. But there are two things that we can try to do to fend off herniation. They aren't foolproof. Sometimes herniation happens despite our best efforts. It happened here. But there are measures nonetheless. They are hyperosmolar therapy and careful blood pressure management. What is hyperosmolar therapy? This is where you use a hypertonic agent to create an osmolar gradient to manage intracranial hypertension. What the hell does that mean? This is where you give a highly concentrated solution, which is called a hypertonic solution. The solute concentration of the solution is higher than that of the opposing cell. Going back to sophomore year science class, the water concentration outside of the body's cell is less than it is inside of the cell, so water will exit the cell towards the higher concentrated solution, the hypertonic solution that you have administered. Still, what does that mean? Let me try to say that in an easier way, because even that makes my head spin when you start bringing up like high school science class concepts. My brain works in very simple ways. So what happens is you give a hypertonic solution. It pulls water out of the cells and dehydrates them. So if you give a hypertonic solution to the patient with a swollen, increased ICP brain, water is going to be pulled out of the brain tissue. The brain tissue is going to be dehydrated and it's going to shrink. And then the patient will pee out that excess fluid. So you give a hypertonic solution to temporarily shrink the brain, relieving some of that ICP. And the result is that you are buying time to give the brain a little more room to swell and hopefully reduce the chance that they're going to herniate. This is strictly a buy time thing. This is not a definitive fix. There are two methods to do hyperosmolar therapy. One is with a drug called mannitol, which is an osmotic diuretic. The other is with hypertonic saline. Both are effective. I don't have the citation in front of me, but I have done some content on this before. I know I did an Instagram graphic on this a couple of years ago, but both hypertonic saline, which is 3% normal saline, the normal saline that we use every day is isotonic at 0.9%. 3% is special hypertonic saline. But 3% normal saline and mannitol work the same way. They're equally as effective. One is not better than the other. So saith the research. In fact, at my trauma center, I have seen both used at the same time. I don't know if that's common or if that's just physician dependent, but do be aware of what hypertonic therapy is. Now, this is not something that is typically done a la pre-hospital EMS. This is usually a critical care thing. Personally, I think that a very good argument can be made for EMS to carry hypertonic saline. Granted, you don't just willy-nilly give it. It's certainly not a benign thing. It's a drug. It's not like the old days of giving normal saline, 2 large bore open IVs wide open. It's got to be carefully dosed because too much of it is bad, although there is no consensus on what is an appropriate dose. And we know that changing the serum sodium level too much, too quickly, is quite dangerous as it can cause osmotic demyelination and a locked-in syndrome. But I do think that in select patients with signs of impending herniation, it could be a useful treatment modality that certainly could be of benefit. Yeah, it's potentially dangerous, but we do plenty of stuff that is potentially dangerous already, like RSI, needle decompression, ketamine administration, shitloads of sedation, you name it. Why not add something else that might help the patients? After all, we are trained to do this stuff. I will quote, though, the guidelines of the acute treatment of cerebral edema in neurocritical care patients from 2020. Citation is in the show notes. First off, they do recommend hypertonic saline over mannitol, which goes against what I just said, that there is no difference between the two. But I stand by what I said because I read a bunch of references that conveyed this. And also, in these guidelines, they don't really give any real justification for why they prefer hypertonic saline over mannitol, other than pretty much just saying, because we said so. And they admit in writing that they only have low quality evidence to support this. But here's what they say about pre-hospital use of hypertonic solutions for hyperosmolar therapy. They don't recommend it. Why? I quote, "Acute treatment of cerebral edema and herniation syndromes is often necessary in the pre-hospital setting." Well, there you go. But they continue, however, well-designed clinical trials did not suggest any benefit from the use of hypertonic saline in the pre-hospital setting on long-term outcomes in patients with TBI. And they also say they didn't see any benefit with mannitol either. I don't really know how I feel about this. I don't like it. And here's why. If you read the paper and you read all the research all around on osmotic therapy and impending herniation, it's very wishy-washy. It also seems like they take some pretty definitive stances based on, to use a research term, a paucity of evidence. Does it work? Does it not work? You hear a lot of stories, anecdotes of it working, but does the data really support it? Read it for yourself and form your own conclusions. But I think that we can all agree that it is just a buy time thing and not a slam dunk. That being said, nobody is saying not to do it. What I take away from reading about it is that philosophically, there's going to be some benefit. Everyone who works in or around neurotrauma has stories of it working, and it's probably not going to hurt the patient. So they keep giving it in the hospital because it will potentially help. The risk of it causing harm is low. And my argument is that if these things are true, they will continue routinely doing it in the hospital if there are signs of impending herniation. Then why does the geography of where it is given, pre-hospital or in hospital, matter? Let's also not just ask why geography should make a difference. Let's also ask, why does the costume of the person giving it matter? What am I talking about, you ask? FYI, we do it on the helicopter all the time. So why not give it to pre-hospital ground EMS? I don't know. I went far more in depth about hypertonic saline and mannitol than I had intended, so enough about that. You know what it is. The other thing that you see very commonly used to mitigate the effects of increased ICP is careful antihypertensive therapy. As I said, patients with subarachnoid hemorrhages are already probably hypertensive at baseline. And once they spring a leak in their head, they are reflexively going to get more hypertensive. A little bit of hypertension is not a bad thing in these cases. This is why you hear the term permissive hypertension thrown around. A little bit of elevated blood pressure will help perfuse the brain. Let's not freak everybody out with math, but let's put a little arithmetic in, as the rednecks around me say, algebra at you here. The cerebral perfusion pressure, which is how well the brain is being perfused, is expressed by the equation cerebral perfusion pressure equals the mean arterial pressure minus the ICP. Mean arterial pressure is the blood pressure. If you want to get really fancy, it is 2 times the diastolic blood pressure plus the systolic blood pressure, and you divide that by 3. I do calculate it all the time. No bullshit. I really do. I use mean arterial pressure every day, whether I'm on the helicopter or whether I'm on the ambulance responding to 911 calls. How do I calculate it so quickly and so effectively? Well, if you take an NIBP, the blood pressure pops up on the monitor, and next to that blood pressure number is a little number in parentheses. That is the mean arterial pressure. The monitor does it for you. So, cerebral perfusion pressure equals the blood pressure minus the ICP. Normal cerebral perfusion pressure is 60 to 80. Less than 60, you're going to get brain damage. Let's say that the ICP is very high at 20, normal's 5 to 10. And let's say that your blood pressure is low with the mean arterial pressure of 50. Normal mean arterial pressure is low and 70. So let's do the equation. Mean arterial pressure minus the ICP. 50 minus 20 is 30, and that is far lower than the 60 that you need for adequate cerebral perfusion pressure. So that is why they would prefer the blood pressure to be higher rather than lower, and that is why lower kills your patient. These are simple mathematics that even I can understand. And if you're going to take the FPC exam or CFRN exam, you'd better know that concept and those equations. But too much blood pressure is bad as well. It leads to more bleeding, more cerebral edema, more ICP. You want a fair medium, a balance. Typically with head bleeds, you want the blood pressure around 140 millimeters of mercury systolic. Subarachnoids can go a little bit higher. Some sources say you want the blood pressure around 160. That is our protocols. But I will quote my coworker whose background is as a neuro ICU nurse. And he was like, 140, great all-around target blood pressure per head bleed. Just beautiful. You use medication to achieve this blood pressure. You don't just haphazardly give meds. I've heard medics before, and they're thinking. I'm not saying they're stupid. They're thinking outside the box with what they have in their protocols. And they'll say things like, I had a subarachnoid patient. Their blood pressure was 240. I don't have drip. Should I give them a spray of nitro if they're hypertensive and I suspect a head bleed? Again, follow your protocols. I'm not your medical director, but the answer is no. That is not stable blood pressure management. That's not a good continuous strategy to keep the blood pressure at a target 140 to 160. You don't want them to drop too low because remember, hypotension is one of the horsemen of the apocalypse. Unless you have a protocol set with the right meds, the right parameters, and the right equipment to deliver those meds, it's better to deliver a patient pre-hospitally to the ER, a patient who has a subarachnoid hemorrhage, with a hypertensive blood pressure like 210 over 120, than it is to deliver them with a blood pressure of 88 over 50 because you were trying to lower the blood pressure. And I don't say this negatively, but haphazardly with less preferred means. Most commonly used in this situation, at least from my experience, is either labetalol or nicardipine. And in fact, it seems that, at least around me, that nicardipine has completely taken over for labetalol. Thank God. I personally hate giving labetalol. I'm not a pharmacist, but 10 years ago, we used to give labetalol all the time for these patients. It's not a drip. You give it in a push, which medics typically like. But I would find, and this is anecdote, but I had plenty of instances where I would give a push of labetalol, nothing would happen. 10 minutes later, you give another push, nothing happens. 10 minutes later, you give another push, and then kaboom, it all catches up with the patient, and they now are hypotensive, which is bad, as you know. Also, labetalol is a beta blocker that will indeed drop the blood pressure, but it will also drop the heart rate. Well, what's a girl to do when Cushing's reflex is at play and the patient is hypertensive and bradycardic, which you do indeed see? Very often these patients will have heart rates in the 40s to 50s. Do you really want to give them a beta blocker if they're that low? Thankfully, this patient was on nicardipine, and nicardipine has pretty much taken over for blood pressure management in subarachnoid hemorrhage. It is a calcium channel blocker that causes vasodilation. It's very easily dosed. It's not a weight-based infusion, which makes it easy for Mongo medics like me. And it's very effective. If you want more blood pressure reduction, turn the drip up. If you're getting too much blood pressure reduction, turn the drip down a little bit. Great drug. You can very easily and predictably manage the patient's blood pressure. So that's what we did. We gave him nicardipine. Well, he was already on nicardipine. We just switched it over to our pump and transported him on it. We didn't have to adjust it. He had a target blood pressure in the 140s for, I think, the entire transport. So we pain controlled him. We switched out his Versed and nicardipine drips over to our pumps, and we switched him to our vent. Now, he was hyperventilating a little bit. Not a ton, but he was certainly overbreathing the vent. And this certainly could have been from his head injury, because once the respiratory center of the brainstem is involved, you get respiratory pattern changes. Hyperventilation is a hallmark sign in a neuro patient, but it also could have been due to him not being appropriately pain controlled. Back in the day, you would have said, oh, he's hyperventilating. Good. We also used to hyperventilate patients with signs of impending herniation, because it would trigger a respiratory alkalosis that would cause the cerebral vasculature to vasoconstrict, or as my dad says, vasoconstrict, thus reducing blood flow and thus reducing inflammation and swelling of the brain tissue. Blown pupil and posturing, hyperventilate the fuck out of them. That's what we used to say. And we don't do that anymore because they've studied it 1,000 times. 1,000 ways till Sunday, and they now know that we were doing way more harm than good. We were hyperventilating them so much that we were completely clamping their cerebral vasculature down, and the brain tissue was not getting any blood flow. It was getting anoxic. So then they recommended, quote, controlled hyperventilation if there were signs of impending herniation. If I recall correctly, back from my protocol set back then, I think they would tell you to target an end tidal of 25 to 30. That is arguably an okay target. The problem is that without a ventilator, you cannot bag a patient consistently like that. You just can't. They've studied it again and again and again. Invariably, humans end up delivering too much, too aggressive ventilation. So then they changed it to controlled hyperventilation if you have a ventilator. And now it seems that in most places, I'm sure it still exists in some places where the medical director is like 110 years old, but most places now just straight up say, don't F with the hyperventilation, just don't do it. So this guy was hyperventilating a bit. If I recall, his end tidal was 26. We had a discussion with the sending ED attending about it. Should we paralyze him and totally take over his breathing? If we do that, neurosurgery is going to flip out. Is the end tidal of 26 actually okay and controlled hyperventilation? Could it be of benefit to him? The consensus was that it's a 9-minute flight, that hyperventilation is not out of control. End tidal of 26 isn't terrible. Just go. And we were totally on board with that. we weren't going to delay an emergent neurosurgery evaluation and intervention because we had this analysis paralysis about the friggin' end tidal value at the sending facility. I'm also not saying to just blow off the end tidal. Ha ha ha, no pun intended. But I think you know what I'm talking about. So we loaded him up and off we went. Halfway through our very short flight, he has a seizure. So we medicated his seizure with 5 milligrams of Versed. And after that, he exhibited some of the most intense decerebrate posturing I've ever seen. I mean, he was contorted, and I was thinking, God damn, he looks like he's going to break his arms. No bueno. He begins Cheyne-Stokes breathing. You could see the respiratory pattern on the end tidal and the ventilator waveform. This is where they have deep and rapid cycles of breathing, followed by apnea, which is totally a herniation sign. And at the time, my partner, Nick, checks his pupils, and that pupil that had been a little bit bigger is now completely blown. My man has herniated. There was nothing else for us to do. His end tidal remained in the high 20s. His blood pressure remained in the 140 range. Unfortunately, nature took its course despite everyone's best efforts. I did think, though, that with his age and the fact that we were flying him directly to a neurosurgeon, that maybe there could be some hope of saving him. Because as I said, I've seen it before, but also I absolutely was not shocked when I did the follow-up on him and I found that he had no reflexes after they evacuated his bleed, that he was deemed brain dead, and that they harvested his organs. So, sad case, but it is a pathology that we often encounter. I thought there were a lot of good learning points here, and you guys asked for more case studies. So, you asked, I answered, because I love you all so much. That's what I got for this podcast, for this case study. Thank you for tuning in. Stay classy out there.